Welcome. I have no financial interest to declare. Dynamic contrast enhanced MRI is a powerful tool to quantify vascular abnormality in the brain. Such abnormalities are common in diseases such as Alzheimer's disease and brain tumors. Shown here is the case of a high-grade glioma patient. You can get an idea of the size of the tumor on the post-contrast T1 weighted image. Zooming in on the enhancing rim around the tumor core, you can appreciate the need for high-resolution DCE MRI protocols in order to accurately capture and parameterize plasma volume fraction Vp and volume transfer constant Kt along the narrow enhancing rim of the tumor. In this work, we propose a sparsely sampled DCE MRI pipeline, which starts by acquiring multi-call case-based data over the course of time by continuously sampling along spiral trajectories which have been rasterized onto a Cartesian grid. On the right-hand side, you can see the evolution of case-based center. During the first portion of this scan session, we successively ramp up the flip angle, starting at 1.5 degrees to 15 degrees in 7 logarithmically spaced steps. After about 5 minutes, you can see the enhancement due to contrast agent arrival in the field of view. In our first step of our pipeline, we used the first portion of the acquired case-based data together with previously acquired B1 plus maps to estimate baseline proton density and T1 maps in a DESPO T1-like fashion. We then use these baseline maps in two previously published methods, that is specifically the Sparse Sense and MoCo framework, to perform the reconstruction of the DCE MRI exam, which has been sampled in the second half of the acquired case-based data. Here we estimate the vessel as a region of interest for the vascular input function, the vascular input function itself, and the tracer-kinetic parameter maps, such as Vp and Ktrans. Location for vascular input function extraction and the vascular input function estimation are notoriously known to be among the great sources of variability in parametric DCE MRI. One of the goals of this work was the automation of the estimation process to allow for consistency in the measurements. We aim to achieve this by constructing vessel mass based on several characteristic features of vascular input functions. As temporal features, we select for short time to peak, short full width of 80% maximum, and high difference of peak enhancement to baseline. We further added the spatial feature known as the vesselness to the list of vessel characteristics. We then chose the largest connected component as the vessel for vascular input function estimation. In the next step, we erode the 3D vessel to exclude potential partial volume averaging. You can see an exemplary result of this process on the right-hand side. We then moved on to determine the repeatability of the DCE MRI pipeline. Repeatability of measurements is a crucial parameter in the development of biomarkers, as it is needed to tell the difference between true effect and occurrence by chance. True repeatability assessment and coffee break-like test-retest measurements are hard to conduct in severely sick patients, such as high-grade glioma patients, since they rely on non-standard of care retest exams. To allow a residual contrast agent to be flushed out of the system, the retest exams have to happen about 3 to 4 days after the standard of care exam, and patients must come back to the hospital. We therefore chose to leverage existing patient data from regular follow-up exams to assess repeatability. Specifically, we used a dataset of 13 high-grade glioma patients, 9 of which are female and 4 male, and all patients are between 42 and 80 years old. Each patient received 3 standard of care DCE MRI exams, spaced between 35 and 126 days apart. Shown here is the progression of a tumor on a T1 weighted post-contrast image to illustrate typical tumor change in that time frame. Here shows the full set of results of one DCE MRI exam. On the left-hand side, you can see the B1 plus proton density and baseline T1 map. On the right-hand side, you can see the vessel mask for VIF extraction and tracer kinetic parameter maps such as Kt and Vp. All maps are acquired for whole brain coverage with a field of view of 240 by 240 by 240 millimeters and voxel size of 1 millimeter by 1 millimeter by 2 millimeters. While all these maps are static, the temporal resolution of the DCE MRI exam to create the tracer kinetic parameter maps is at 5 seconds. We next assess the repeatability of VIF estimation. Here shows a representative case of 3 vascular input functions for the first visit and the 2 follow-up exams. The vascular input functions are in overall good agreement. To quantify repeatability, we followed an approach similar to Giorgio et al. By assessing repeatability of characteristic features of vascular input functions. We therefore computed the area under the curve, the area under the first pass, and the peak concentration, and determined the within-subject or coefficient of variation for these features. All coefficients of variation are between 13 to 18%. To avoid spoiling measurements of repeatability by tumor progression, we selected 5 healthy tissue regions with varying degrees of enhancement: the inferior nasal concha, the choroid plexus, the temporalis muscle, scalp fat, and white matter. All regions span at least 3 slices, although only one slice is shown here for presentation. With the exception of the nasal concha, all ROIs are drawn contralateral to the respective tumor site. Due to the high resolution of the DCE MRI protocol, the volumes for most ROIs span several hundreds of voxels, as you can see in this table. This slide shows preliminary repeatability results for the median of trace kinetic parameters for each of the 5 reference tissue ROIs. On the left-hand side, preliminary results for VP are shown, right shows K-trans. Each dot indicates a pairwise comparison between 2 out of the 3 visits for each patient using the Sparse Sense framework. Different colors correspond to different tissues. While this is still work in progress, we computed the initial estimates for the within-subject coefficient of variation for the median histogram statistics. With the exception of white matter, the coefficient of variation for Sparse Sense framework tends to be around 40%, while it varies greatly between 40 to 125% for the MoCo method. In conclusion, the use of healthy reference tissue in clinically indicated exams may be a viable way to perform test-retest repeatability exams for DCE MRI in the future. This could essentially provide a way to bypass ethical and practical hurdles regarding contrast injection and patient recruitment, especially of very sick patients who understandably do not want to spend more time than necessary in a hospital. While this is still work in progress, the preliminary results for Sparse DCE with coefficient of variation of 40 to 50% appear worse than the current conventional DCE MRI standard, which specifies about 20% for K-trans in the current KIBA profile. With this, I would like to conclude my talk by acknowledging the research support from NIH and the Canadian Cancer Society. I would also especially like to thank Samuel Barnes for providing GPU-Fit, which is a framework for fast GPU-based DCE MRI model fitting. Lastly, I would like to thank my collaborators and you for listening and having interest in this talk.